This is the MedicCast, May 30th, 2011.
Transmitters? We don't need no stinking transmitters.
This is the MedicCast, a podcast for EMS providers by EMS providers, featuring EMS news, products, tips, tricks, and commentary. So grab your gear and glove up. Here's today's show with the pod medic, Jamie Davis.
Well, good day and welcome to this week's episode of the MedicCast. I'm your host, Jamie Davis, and I'd like to welcome everybody to the program this week. If you haven't already done so, I urge you to head over and check out links to everything we've discussed on this and every other episode over at the MedicCast website, mediccast.com/blog. You'll find links to all those pieces of information from every show there, articles that are posted, commentary, and all kinds of things. And of course, you can leave your own comments on any of the articles as well. I get an email whenever you leave those comments, so I can respond back to you, and it can start a dialogue with other readers and viewers, listeners of the show. So check that out. Of course, there are a lot of viewers of the show, as we are talking a lot about video versions of programming lately. You can find videos from the MedicCast, including the studio video recorded when recording the audio version of the show, and also other short segments of the MedicCast over at mediccast.tv. That'll basically take you directly to that section of the website. And I would urge you to follow up on that too, if you like to check that out. Of course, you can also get the MedicCast via things like the Apple TV set-top device, the Roku device, and more channels on different types of set-top boxes coming soon. So keep paying attention, and we'll keep putting out this information for you in every single way we can think of doing it. I want to get into a couple of things from a few listeners, and at least one in particular checking in via Facebook. So let's go ahead and get into that segment as we touch base with our listeners via listener mail. So as we touch base and check in with some of the things that we get from listeners from time to time, it's great to hear from you. I want to let you know again, as I say every week, I try very hard to respond back to you when you send me a message. It might take me a little bit to get back to you, but I try to respond to every single email. If you haven't heard from me in a couple of weeks, send me another email and put "Hey, stupid" in the subject line, because I might have forgotten or misplaced your email, but I really try to get back to everybody in at least a reasonably timely fashion. One of the people that touched base with me actually contacted me not by email, but by Facebook. And listener Adam is checking in. Adam just wrapped up his EMT course that started in the fall, and he listened to the show all the time and just wanted to thank me for helping him through EMT and let me know that he's starting his paramedic program and looking forward to using the MedicCast to help him out there as well. And I just want to let you know how much it means to me when you check in with me and let me know that something I've said on this show has helped you out in your classes. That's what it's all about. I have advertisers on the show. I got to make this profitable in some way, and I continue to hope you will support those advertisers. We try to keep it short and sweet and only one or two, but certainly it is an opportunity for you to support the show that way. But I want to make sure that you're getting something out of the show. And really the reason I do this, it's a lot of work, and I don't make that much on it to really make it worth the hours and hours I put in researching and doing everything else. But it's wonderful to hear from each of you when you tell me, hey, the MedicCast helped me pass my classes. The MedicCast got me through paramedic school. The MedicCast helped me make a decision that I wanted to be an EMS professional. Whatever the case may be, I just want to thank you for taking the time to drop me a note and letting me know that. I will continue to produce this show. I'm working hard to get it done. Sometimes I don't get it out every week, but I do make sure we're getting it out most of the time, every single week, and it will be out there for you. And of course, with over 250 episodes out there, I've probably covered almost every single topic that you might cover in an EMT or a paramedic class somewhere on the show. So you can go over to the MedicCast site and search for information you need in a past episode or an article that I've written there. And I hope you will do so. And I hope you will also contribute back to the Medicast. Share your voicemails, your comments. If you wrote a really good segment or training session for your service, if you're an education officer and supervisor, share that with me here. Send me a segment of it. Offer to set up a interview call with me, and maybe we can sit down and chat via the phone and record something for the listeners so that they can hear what you're doing in your service and take some of those training ideas back to their colleagues and help create enthusiasm there as well. So I really appreciate it. I continue to thank you for becoming really a community here at the Medicast. And like Adam said, this is a group effort. And I hope that, Adam, you'll continue to stay in touch. Let me know how paramedics going for you. And let me know if there's anything I can do to support you and your classmates. And if you let me know where you're going to school, maybe I can give you all a shout out the next time we do a show. I know some people cringe when I say shout out, but hey, I'm an old guy. I don't stay too up with the times, and I'm going to say shout out if I want to. Anyway, get in touch with me just like Adam did. You can contact me over at Facebook. You can find me under the handle Podmedic there, and on Twitter and a lot of other places. So facebook.com/Podmedic, twitter.com/Podmedic. You can catch me there. You can check out the Medicast fan page at facebook.com/Mediccast. And of course, don't forget to email me or send in a voicemail. You can call in 941-306-3342, 941-30-MEDIC, or email me at podmedic@mac.com. Let's jump into this week's news item, and we'll kick off with those news items with a look at bed bugs. Yeah, I know, bed bugs. They're a pest, they're a pain. In the past, though, we've talked about it here and maybe more so over at the nursing show and at my Insights in Nursing panel show, talking about what does it really mean, bed bugs getting into hospitals and ambulances and into your own home? Because up till to date, they have not been seen to be a vector for any kind of disease. And of course, that's the big problem with things like mosquitoes and other insects and other animals that might be getting into places and infesting them, is that they can be vectors for disease, for carrying a disease between humans as they bite one person and go on to the next person. And to date, there's been no sign that bed bugs are indeed vectors for anything. And that's a good news item because they're really hard to get rid of. But a recent article that I found over at webmd.com may be inciting some panic among some people about bed bugs, because do bed bugs spread MRSA? ? Is the headline. Well, do they? Well, no. There's no evidence that bed bugs spread MRSA, but when they looked at a few of the recent homeless who had been picked up and brought into the emergency room for medical issues, and they found bed bugs on them, somebody thought it would be a good idea to go ahead and test the bed bugs to see if they had any diseases on them, like infections. These are the insects that live on and around the skin at certain times of their life cycle before they leave to go hide in an area. They only come out to feed occasionally. So, but when they're on you, if they had something like MRSA on them, they could bite you and leave you with a skin infection. It makes sense, right? Well, maybe, maybe not. What indeed was found was that they did find medication-resistant bacteria on these bed bugs that were found on these couple of homeless people that came in. So this isn't a huge population. If you're a statistics person, the N is almost as small as it can get. 2 or 3 homeless people does not a large sample size make in any case. But it is notable that there was detectable signs of this bacteria. Now, this bacteria lives out there in the wild. Yes, there's hospital and healthcare acquired versions of these superbugs, but the community acquired versions are almost as bad in many cases and much more prevalent, and we're seeing increases of it. My question, of course, would be, did the bed bugs give the homeless guys MRSA, or did the homeless guys give the bed bugs MRSA? In other words, did the bed bugs have this on them when they got there, or did it get transferred to them because they were rubbing up against the skin while they were there? And could they transfer it to someone else? So it's hard to say. But certainly we're getting this from the community in some way, whether it's in living, on surfaces we touch and, whatever the case may be. So be aware of this and make sure that you are just reading headlines carefully. If you see some headline asking a question like that, do bed bugs spread MRSA? If the bed bugs were found to spread MRSA, it would say bed bugs spread MRSA. That would be a much more compelling headline. So if it's asking the question, it probably is not something to be too awful worried about. Read the article, educate yourself, but don't be one of those people who runs out, sees a medical headline, and thinks you know everything about the article. Often those headlines are very misleading and can lead you down a path that can be dangerous. And we have all had patients that have heard the recent news headline, just somebody spread the word to them and they read the headline, didn't read the article, and they think they know everything about a certain problem and they stop taking their meds. We've seen that patient time and again. We need to be, again, on the front lines, since we are there anyway, of educating these patients about what's going on medically in the community. Just educate yourself. You don't have to be super knowledgeable about every little study that came down the pike, but if something makes mainstream news, take the time to look over the article so you can talk intelligently about it and educate people during that trip to the hospital. Next up is an article that's a little concerning. I don't usually put articles about EMS professionals that have been convicted or charged or convicted of a crime. I think it doesn't matter that they're EMTs or paramedics as much because everybody that gets charged with a crime has some profession, right? So it's not as notable. However, in this particular article, it is concerning. Now, this is a case about an EMS chief that was allegedly found to have been driving under the influence of alcohol, a DWI charge that was later downgraded. We don't know if it actually happened. Of course, he hasn't been found guilty, but certainly there was some cause to at least file the initial charges for DWI. As I'm always going to say, I'm not going to comment directly on this particular case, but I am going to say this to you. I think it's reprehensible when any EMS professional goes out there and drinks and drives. Okay? Now, I'm not saying this guy did it. That's for the court to decide. But I am going to tell you what my opinion is. How can you be involved in a profession that actively sees the aftermath of those horrible situations when a drunk driver comes along and he kills an entire family and he's only got bumps and bruises? I've been there. Many of you have been there. If you're a student, you will soon be there. You're going to see that patient. You're going to have to treat that drunk with compassion. You're going to have to take them to the hospital, treat them like a patient, and not be angry and, do all the things you'd like to do to that guy for being drunk and driving. So why would you then therefore go out or let your coworkers go out and drink and drive? I want to go out and party as much as the next guy. But when I do, I make sure somebody else is driving. Often I'm the designated driver. I don't drink that often, so I'm happy to just drink soda and drive everybody home. One of you needs to take that responsibility or take a cab or other transportation and not put yourself behind the wheel. I don't ever want to see an EMT, a paramedic, let alone an EMS chief, be put in a situation where it looks like they've been drinking and driving. It looks bad. It makes us hypocrites when we talk about safety messages, and it just doesn't do any of us any good. And God, would you hate to be that person that everyone else has lived with, that drunk who killed a family and has to ride to the hospital for bumps and bruises in the back of an ambulance, because you know exactly what that provider is going to be thinking about you. So don't put yourself in that situation. Enough said. I had to go there because I had to have a comment when I saw that particular headline come across. Again, don't know whether it's, this person hasn't been found guilty. We don't have any evidence that, I'm not a court of law, and I'm not saying that. I'm talking about in general, and I'm talking about you, the community here at the MedicCast. Let's be responsible and approach our alcohol consumption responsibly. Finally, we've been talking a lot, especially since the new guidelines for cardiac care came out, the 2010 ECC guidelines were released, about EMS collecting more data, that we've really been lax in collecting hard data about how we take care of our patients and the positive and negative patient outcomes that occur based on how we care for our patients. Up till now, our most important statistic has been a time-based statistic. How fast did we get to the patient? How fast did we leave the station? How fast did we get the patient to the hospital? We are all about the movement from place to place and transportation. But what does that say about how the patient did? It doesn't say anything. Yeah, there is some speed essence to treating true emergencies. We think about the golden hour. We think about other things that we've been taught and learned about over time that critically we need to get to. Obviously, we need to get to critical patients faster. Cardiac arrest patients, time is essentially the only thing that's going to save them. If we can get there early enough, or bystander CPR starts early enough to save them, that's a time factor. But it's not the only factor. What about the educational level of the provider? Different types of protocols being used in different places. There's a lot of things that we don't study. And when you start looking at it, you know, if I were to put my nurse's cap on and turn and talk about working in a hospital, hospitals have to report on everything. The Joint Commission requires hospitals, and the federal government requires hospitals to report numbers on adverse outcomes, on things that may have been their fault, things that happened to patients that weren't their fault. They report on everything in the hospital setting. You know, it's ridiculous the amount of different pieces of information that get put out by hospitals. And there's a lot of data out there. It's not a lot of data about those kinds of things from the EMS sector. So I found this article, and the reason I bring that up is that there's an article here from Australia, and it's looking at the state government in, I believe it's Victoria, being criticized for using a previous year's statistics guidelines. So here we have an organization that's reporting statistics, but they're using old standards to report that they are within compliance. So I don't know what's going on in Australia. Clearly, we need to make sure that we have the appropriate information and statistics. There need to be standards. I think there needs to be a national standard. The Joint Commission needs to turn its eye, and I hate to say this because if you've ever been on the other side of that where the Joint Commission comes in and accredits your hospital, it's a nightmare. But I really think there needs to be some focus from the Joint Commission on the pre-hospital transport stage and patient care, and really start setting some reportable standards that we can follow up on and let people know what's going on with our patients, besides just how fast we got there. So I urge you to check out this article and maybe let me know, what are you reporting? When someone asks you how your service is doing, I know there are a lot of supervisors and leaders in the EMS sector that listen to this show. What are you reporting on? What do you have to turn in at the end of the month that tells somebody how well you did? Was it just response time? Or is there something about outcomes for your patients? Is your medical director following up on patient outcomes? I'd like to know that. So get back in touch with me. Send an email in to podmedic@mac.com. Or if you want, go ahead and call in and contact me via the voicemail line 941-306-3342, 941-30-MEDIC. And of course, you can also leave messages on Facebook, Twitter. Just get in touch with me and share your thoughts about these or any of the other items in the news this week. And I'd like to start off this tip of the week. Again, we're going to pick up where we left off last week on our National Registry Cardiology Skills Stations. And this week, we'll be looking at the ALS Skills Stations. Wait a minute, you BLS providers and BLS students out there, don't turn away. Okay, you will be working with ALS providers in your practice. You're already working with ALS providers in your practice, and there's no reason you shouldn't have a good understanding of the steps that an ALS provider goes through when they're taking care of a cardiology patient. You can readily assist in treatment and transport of that patient and be better prepared to help out when things go south for some of these patients. So be prepared for that. So let's go ahead and look at this. Now, for National Registry, the cardiology skills for ALS patients include dynamic cardiology and static cardiology. Those are primarily what we're looking at. There may be some cardiology components associated with the patient assessment stations, and so if there are, be aware of that. Again, those are a little bit different. You know, those verbal assessment stations that they do can be on anything. So you really need to have a whole picture of what's going on with the patient, and there may be cardiology aspects associated with it. I know there were for mine. Not, just part of what was going on with the patient. It wasn't the primary problem, but there were cardiology issues that needed to be dealt with. Dynamic cardiology. First off, again, BSI. Dynamic cardiology is an active skills station. It's really a mega code where you're going to see a patient presenting with a rhythm, and you'll see 3 more rhythms through the course of this station for 4 rhythms total. So patients are going to respond to your treatments, and the rhythms are going to change. And you're going to have to adapt your treatment protocols for what's been going on, including keeping track of meds that have been delivered and not giving patients too much of a med because the rhythm changed back to something that might cause you to forget that you already gave them all of the atropine you're allowed to give them, or you might have given them all of the lidocaine or amiodarone that you're allowed to give them. So be aware that this could happen, and keep an eye on it, and keep all these things in mind. Dynamic cardiology starts off with BSI. You want to make sure you're verbalizing BSI and in all these stations when you're actually going to do hands-on work. And if it's a verbal station, you want to verbalize it there especially. Again, wearing gloves will protect you from some of that. So if you forget, you won't have to worry about it. You were wearing gloves. You want to check the patient's responsiveness. Again, we're assuming now this is an unconscious patient. Usually they start off with a patient in some form of arrest. So you're going to go ahead and check responsiveness on this patient. You want to make sure you go through and are checking your ABCs. Now, for the 2010 ECC guidelines, remember, we're looking at CAB, compressions first, then airway and breathing. However, if you are there with a monitor, and you're going to be able to attach that to the patient immediately. If there's no one else there, you would direct them to start CPR, and then you would go ahead and attach the monitor and get a quick look. So you have to kind of look at how the station is set up for you and respond appropriately. Talk to your instructor about that. They should be able to give you some insights into how that station is laid out specifically. Again, look at the testing documents and see what's there for you. But again, you'll want to follow the new guidelines, which is CAB, compressions first. Then you'll check open your airway and check for breathing and ventilate the patient before resuming compressions again. Do that first. However, always get the pads on first if that's what you have with you right away. You can do both at the same time, but that's what you're going to do. You want to go ahead and get CPR started. You're going to get your ECG attached to the patient. This can be leads. It can be pads or paddles, however you're going to do that. It's appropriate to do a quick look with pads, with putting the pads on or the paddles on and doing a quick look. It's also appropriate to put the leads on the patient and get a look at the rhythm, and then put the pads on as needed. So it's not inappropriate or wrong to do either or. In a situation where it's quick, putting 2 pads on may be easier than putting 4 leads on a patient. We're not going to do a 12 lead at this stage, but we will talk about that. You're now going to interpret the rhythm. So CPR has been started. You're now looking at the rhythm. Interpret the rhythm. You're going to have to name the rhythm out loud and say what it is. You now have to appropriately manage the rhythm. So if you've got a VFib, you're going to say that's ventricular fibrillation. I'm going to go ahead and deliver a shock according to whatever your protocols are. You might be high energy or low energy, so it might be 200, set to 200 joules, and you're going to go ahead and deliver a shock, or 360 joules and go ahead and deliver a shock. Whatever the case may be for your particular device, because they deliver that energy slightly differently. You need to know what your device is doing, but you'll check that out. Now that you've delivered the shock, you go ahead and you manage to get people to start CPR again. You're going to talk about how you're going to start an IV. You're going to make sure that the airway is open via BLS means, get an IV started, and begin your round of ACLS medications for this particular rhythm. You'll now see that the patient is converted to a new rhythm after some of your interventions. You'll have to assess and verbalize what the new rhythm is. So, wait a minute. It looks like they've moved into a sinus rhythm. What do you do when you see a patient convert to a sinus rhythm and you're looking at the monitor? Well, they're still doing CPR, so you're going to do 2 minutes of CPR while you watch this sinus rhythm on the monitor, and then you're going to check for a pulse. You check for a pulse, and you're going to, at the next break, check for a pulse. You have a sinus rhythm, and you're going to find that they're in PEA. Okay, if that's the case, you need to go into your PEA protocol and follow your interventions. Your interventions will lead to another rhythm change, okay? You want to make sure along the way that you're appropriately checking for pulse, blood pressure, or patient status based upon what you see in the rhythm monitor and what you get back as feedback on what's going on with your patient. So again, you got to manage all these things. This is one of those things where you really need to practice and keep these things in mind. Practice, practice, practice. Come up with as many scenarios as you can. There are lots of scenarios that are presented in your textbooks. You can find other scenarios listed online. You can just go ahead and make up scenarios for yourself and run through every kind of rhythm change and treatment setup that you can think of and see if you can keep track through 4 consecutive rhythm changes. You're going to have these 4 rhythm changes, and you're going to state the rhythm, manage the patient as each rhythm presents, manage the patient appropriately, and then go ahead and be ready for the next rhythm. You're going to do your patient assessment, your total reassessment, patient care, prioritizing and transport decision are all part of this scenario as you manage this. So, you might end up with a patient that started in cardiac arrest, ends up at the very end in the 4th rhythm in a sinus bradycardia requiring that you have a dopamine drip going because they're hypotensive and bradycardic. Whatever the case may be, you need to kind of follow through your protocols and see what's going on with that. Again, follow the guidelines that your instructors provided for you or the protocols for your state or jurisdiction if that's what you're testing under. Usually National Registry will test under the current ACLS guidelines, so you'll need to be up to date. Usually they're going to say these are the 2010 ACLS guidelines that you're going to follow. It should be starting about now that they're going to be requiring that. So if they haven't, they will soon. And you should be aware that you might need to know that. So find out. Make sure you're providing high flow O2 and everything else that needs to go along the way. They're appropriately ventilating the patient. You're verifying when are you going to drop the tube. All those things might happen at some point along the way. And you'll need to be thinking about, in the process of treating this patient, when is the best time to go ahead and intubate. Usually you have enough extra hands there to just direct it. So you're verbalizing these things. You're going to be the person running the code. And if you're running the code, you are the person who will be just standing there saying what to do next. You have the imaginary trained paramedic who can intubate at the drop of a hat. You will have highly qualified, good CPR compression performing firefighters that are there to back you up and perform compressions and manage BLS CPR for you. All those things are happening. There's another guy pushing meds. All those things are going to happen, but you have to tell them what to do. And you have to verbalize what the next treatment in this chain is and what you're going to do based upon changes in rhythm. So there are critical fail points for the dynamic cardiology station. Failure to deliver the shock rapidly. Initially, generally that first rhythm is going to be a shockable rhythm and a patient in arrest. So failure to deliver a shock rapidly. You might have to pace a later patient. Again, recognizing and being able to put a shock in place. You might have to cardiovert a patient. Be prepared to deliver that shock appropriately and rapidly. If you failed to check your rhythm prior to shocking, if you slap the paddles on, charge and shock this patient before you check their rhythm, well, aside from the fact that I will want to come down there and slap you, you will fail. And you should fail. So don't get ahead of yourself. Again, remember back to when we were talking last week in the BLS section, in the beginning, I talked about how to prepare and go into the skill stations. One of those things is before you start, take a deep breath. Before you tell the instructor, okay, go, you're going to take that deep breath. This slows you down, taking that deep breath. The reason for that is you don't want to miss steps along the way because your brain thought you did it and you were just going too fast to even think about it. If you fail to clear your patient prior to delivering a shock, if you fail to deliver a shock that should have been delivered, if you didn't follow the appropriate shock sequence, if you have a shock sequence in the protocol or guideline for what you were doing, and this might more appropriately apply to how you try to get capture during pacing. If you're have a patient that you're pacing and you're trying to get capture or cardiovert them at a low energy level, what is the sequence to bring up that energy level? If you fail to rapidly resume compressions in CPR after delivering a shock or any other time there might be an interruption, remember that 10-second window is the maximum you have, and it should be a lot shorter than that. We should be aiming for just a couple of seconds interruption whenever possible. If you didn't correctly manage the airway, again, starting with BLS procedures and airway adjuncts and moving up to securing the airway via ET tube as appropriate, that would all be a fail point. Some more critical fail points. If you fail to deliver high flow O2, if you fail to identify or treat 2 or more rhythms. So guess what? 4 rhythms, folks, you have to miss 2 of them. So you can miss 1 and make a mistake and still pass this station. You could go down a wrong path and correct yourself and say, wait a minute, that's not what I'm treating here, and the rhythm's now changed to something else based on what I did. You missed the first rhythm, but you're now moving forward. So keep that in mind. You have to miss 2 rhythms to fail this station. Now, you might misidentify the rhythm, but then treat it correctly, or vice versa. So again, those mistakes could happen, and you could fail if you miss 2 or more of them. Or if you order an inappropriate drug, or you order a lethal dose of the correct drug. Again, that's a fail point, and it should be. So know your protocols, memorize your ACLS guidelines, know your drug progressions, know how much is too much. What is the maximum amount of a drug you're allowed to give to a patient, and how much have you already given them in other segments of this scenario as the rhythms have changed? That's important to keep in mind, because you might have maxed out at some point some of the medications. If you fail to recognize, treat VFib, VTach, or asystole, you fail. Okay? So while I said you can misidentify rhythms or mistreat 2 or more rhythms, there are 3 rhythms you have to get right. You have to get VFib, VTach, and asystole correct. And heck, if you can't identify those after going through a paramedic program, I would like to know how you made it through the paramedic program, because quite honestly, these are pretty straightforward. These are the big 3 that you should be able to recognize, and then the 4th one would be normal sinus rhythm. So, you know, obviously VFib, VTach, and asystole are some big cardiac arrest rhythms, and you should be aware of what they do and how they work. Let's talk a little bit about static cardiology now. The static cardiology station is actually the one station I was like easy peasy and relaxed for, because it really is a station I think that caters to the way I learn and the way I think about things. And maybe that doesn't work for you, but this is what I'm going to walk you through why I think this station is one of the easiest stations to come down the pike. Now, it requires a couple of things of you. It does require that you are reasonably skilled as a student at reading basic cardiac rhythms. They're not going to give you anything crazy or hard to read. These are textbook rhythms that they're going to hand you. So you need to know what 2nd degree and 3rd degree heart blocks look like. You need to know what a bradycardia is versus a tachycardia. You need to know what VFib looks like, what VTach looks like, what supraventricular tachycardia looks like. All those things you need to kind of have a handle on. And so that's what this is testing, is can you read the rhythm and briefly talk about the treatment profile for this patient. So preparation. When you prepare for this, review your main rhythms. And again, look at different versions, textbook versions of that rhythm. Try to signify one of the things I see trip people up all the time. What is the difference between, you know, a 1st degree, 2nd degree type 1, 2nd degree type 2, and a 3rd degree heart block? You need to really have a handle on that. I've seen more people get tripped up by that station than anyone else, just because 1st degree, 2nd degree, 3rd degree heart blocks, because they just couldn't see the difference between, you know, type 2 and 3rd degree. Or they were missing that there was a 3rd degree heart block going on. Some people look at a 3rd degree heart block, and because it's irregular, because of the fact that there's, you know, the irregularity, the disconnection between the top and the bottom of the heart, they look at it and they might think it's a slow VFib, a slow atrial fibrillation. You know, so be prepared, know those things, and move forward. You're going to get 4 different strips, and each of them will have a brief scenario paragraph that you'll read, okay? It's not read to you. You'll read the strip. the preceptor will sit there and there is no additional information they can give you. They know what's on the strip, but they don't know anything else. And the important thing to keep in mind with this is there is nothing else. If it's not on the strip, it didn't happen. It is not existing. You get a 6-second strip. You identify the rhythm, you read the paragraph, you treat the patient. Okay? It is don't read anything into it. Don't say, well, what if? If you find yourself thinking, well, I wonder what's going to happen with this patient, or I wonder why this is going on, you don't have that information unless it was in that paragraph. You shouldn't be wondering anything. You should know everything you need to know. And so basic treatment. For instance, you have a person that's out at a playground and they're found they collapsed, they're not feeling well. You find that they are bradycardic, they're sweating profusely, and they're complaining of lightheadedness, they're very sweaty, and they're outside, and you find that they're bradycardic. On the rhythm, you got a sinus bradycardia going on. There's no any kind of ectopy. It looks, just a classic sinus bradycardia. What's the treatment for this patient? Well, they were out jogging. They got lightheaded. They sat down and they sat there until help came. And so you're out there looking at them. What do they need? Well, do they need to be paced? No. Do they need an IV? Or something to speed up? How bradycardic are they? Maybe they're bradycardic at 50. And you ask them, well, they're a marathoner. Well, again, if it's in the scenario and you have this all written down there, this patient may be bradycardic because they're dehydrated. They may be bradycardic for a number of reasons. You don't need to necessarily treat that. You may be able to manage them with oxygen, monitor, and transport. So O2 IV monitor, transport. All right. Not every patient gets major interventions. And that's one of the things they want to know you know how to do, is not go to the big guns right off the bat. So again, that's just a scenario patient. Again, it's probably a lot more information you're even going to get in that paragraph. It's going to be even more simple than that. So what you have there is what you've got. Treat it. Okay. If it says an unconscious patient and a set of vital signs that shows they're hemodynamically unstable and they have a supraventricular tachycardia going on, that patient's getting cardioverted. You know that, I know that. You've identified a narrow complex atrial tachycardia, you're going to call it SVT, you're going to go ahead and you're going to cardiovert that patient because they're unconscious, they're hemodynamically unstable, they are classic cardioversion patients. That's what they want to see you know. You're going to go ahead and move on to the next rhythm. You may pass to the next rhythm and come back to one that you weren't able to figure out in the time frame that you have, but you have only 6 minutes to complete this station. Oh wait, that doesn't seem like a lot, right? Well, just remember, it's 6 minutes to complete this station, but it's really not much more than you saying, all right, that is sinus bradycardia. The patient is otherwise stable. I'm going to give them oxygen. I'm going to give them a nasal cannula, 6 liters per minute, hook them up to the heart monitor, start an IV, KVO, running with normal saline, and we're going to transport them to the nearest facility, monitoring them and reassessing them along the way. That's it. You're done. That took what? 30 seconds? You go on to the next card. Okay, that's how long it takes. You don't have to go any more in depth than that. You don't have to ask, well, I'm going to wait and see what happens. No, all you have is what's on the card. Don't make it harder than it needs to be. Some critical fail points. If you fail to correctly identify the rhythm 2 or more times, so again, out of these 4 cards, you can miss 2 rhythms. If you fail to properly treat 2 or more rhythms, you will fail. If you fail to verbalize or use BSI precautions. This doesn't say this specifically, but sometimes preceptors are sticklers for this. So even though this station doesn't specifically say that BSI, failure to take BSI is a fail point, I'm going to say that you may have a preceptor that considers it that anyway. And based on the testing station or testing center, they may uphold that. Again, you should be thinking about BSI. So I have no problem with them doing that to you. So just be prepared. There's a lot of resources out there. Again, download the skill sheets, all of them from the National Registry site. There's a link in the show notes over at mediccast.com/blog, and you'll find the show notes for this episode, and you can click that. Again, I would, if you haven't already done so and you haven't listened to the previous episode with the BLS version of the National Registry Skills Station, whether you're ALS or BLS provider or a student, you might want to check that out. It's a great review and gives you some good thinking points if you're an existing professional out in the field already. What are you doing that maybe you should be doing that you haven't done in a while? Is there some step or stage along the way that you could use a refresher on? I know it's insulting to say that, but I'm going to tell you, we get in ruts and we get in habits, and sometimes we need to get those habits and ruts broken. So keep that in mind. And in the meantime, make sure you follow up on all of this information. And that's going to wrap up this week's episode of the MedicCast. I want to thank everybody for checking out the show this week and remind you to follow up on all of the information you'll find in this and every other episode over at the MedicCast blog, mediccast.com/blog. And you'll find a link for the show notes right at the top of the page. Click that and find the most recent episode listed first and all the other episodes listed there. Of course, there's the search bar at the top right-hand side of the page, so you can search for topics that we've covered over the last 6 years here at the MedicCast. I think you'll find just about everything that you need over there, and including other articles and information, links to the Facebook fan page, and a lot more, all available over at the MedicCast site. And of course, don't forget you can sign up for the newsletter for the MedicCast over there as well. Get all of the show notes delivered to you by email every week. And it's a great way to just get those links and things sent directly to you, connecting you back to the show. So whatever it is you do, go ahead and follow up on the information you've seen and heard in this particular episode. I do want to thank everybody for getting in touch with me and continue to do so. Send in those emails to podmedic@mac.com. You can also call in on the voicemail line 941-306-3342. 941-30-MEDIC is your access point to call in on the voicemail line. Leave your voice message that can be played here on the show and let me know what your thoughts are about this or any other episode, and share your ideas for future episodes as well. You can catch up with me under the handle PodMedic at Twitter, Facebook, and other places online. And don't forget to become a fan of the MedicCast over at the MedicCast fan page. And that's at facebook.com/MedicCast. Click the like button at the top of the page and become a fan of the MedicCast. We're going to go ahead and close out today's show with some great PodSafe music. This is Johanna Staley. We've played her songs here before. Like to listen to it again, so I'm going ahead and playing the song Nothing I Would Change. If you like what you hear, you can find a link to her site as well as a link to her music over in iTunes. Click that link and pick up one or two of her songs if you like what you hear. And also, let her know you heard it here on the MedicCast. That's it. I'm Jamie Davis. I'll be back again soon with another episode. In the meantime, don't forget to keep some important things in mind. Scene safety, BSI.
Change. trained to